Adobe Acrobat Studio, your new foundation. Use PDF spaces to generate a presentation. Grab your docs, your permits, your moves. AI levels up your pitch, gets it in a groove. Choose a template with your timeless cool. Come on now, let's flex those tools. Draft, design, deliver, make it sing. AI builds the deck so you can build that thing. Do that, do that, do that with Acrobat.
Learn more at adobe.com/do-that-with-Acrobat.
This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME through MyCares and Michigan State University. The links for the CME are in the show notes. This week, we're going to be discussing dental problems caused by buprenorphine. How are you doing tonight, Sonya?
Doing really well, John. How are you doing?
I'm good. Pretty excited to hear about anything about teeth. I feel like in another life, I could have been a dentist.
I'm just like super undereducated about teeth. I don't know anything. So I'm admiring of my dental colleagues who can take care of these problems.
It's interesting. I live in a neighborhood and many of my neighbors are dentists. There's like no doctors, like a dentist neighborhood. They live very much more interesting lives than me. They're always doing stuff and having fun. And but then they do ask a lot of medical questions for me. And I ask a couple dental questions, but thankfully I don't have many of those issues.
Our dentist, like the kids' dentist, our family dentist is a personal friend. Also, he's got a very fun life, and always happy to spend time with him. If you're listening, we appreciate your care, Dr. Seidel.
It's good. It's good to have an end.
Yeah, that's right. John, let me tell you what I've been thinking about in addiction medicine news this week. So there was an article, kind of like an opinion piece in JAMA Psychiatry about making naltrexone for alcohol use disorder over the counter. It's a relatively safe medication, doesn't have a lot of side effects. You can take it for alcohol use disorder. The dosing doesn't need to be too precise. Hard to do a lot of damage with it. So the question is, and there's a very, as we've talked a lot about before, alcohol use disorder is very undertreated. And a lot of patients who have alcohol use disorder would like to take medication that would help them. But something like 2% of patients with alcohol use disorder get any kind of medication. So making this one over the counter might be a step in improving those numbers. So what do you think? Should naltrexone become over the counter for alcohol use disorder?
That's a good question. I don't know. I know we talked about this beforehand. I'm not clearly that opposed to it. I think if it was labeled appropriately, I mean, I guess the concern that we discussed before would probably be like precipitated withdrawal if someone was also using opioids. Although I feel like my population that uses opioids really is aware of that. And it's a very patient-centered metric for them that they would be looking out for. So maybe it's not as much risk as you would think.
It's just so hard to say. I mean, I was a little bit horrified just today, and without giving too many details, a new patient in the office who was taking opioids and given naltrexone after getting sort of vague advice from psychiatry to wean yourself down and off the opioids before you started, and it will help you stay off them. But no discussion of what actually is precipitated withdrawal or what it would mean to wean off the opioids or anything. So this patient just took the naltrexone and then ended up with a horrible precipitated withdrawal and a prolonged hospital stay that was very traumatic and very serious, including intubation. And so real harm was done with this prescription for naltrexone given to someone who was not fully educated on the risks and how to take it correctly. So I just saw that today, but that's a little bit of an anomaly. I'm not sure I've seen a lot of other harms from naltrexone.
And in fairness, I mean, that person was using what they thought was medical guidance, right? It wasn't like they were doing research. They kind of like listened to what someone told them to do that was a medical community member, right? So I feel like,
right,
would it be different if they had initiated the medication themselves and had done their own research? I don't know.
Yeah, I don't know. And the labeling for over-the-counter medications, of course, is different standards than the labeling for prescription drugs. But I think it'd be interesting. I actually do think a lot of patients could maybe use it effectively, but there'd have to be a pretty significant, I think, education campaign on how to take it correctly and when to take it. But it's a great thought. I mean, it's a great way to try to increase access to care for alcohol use disorder. I've also seen opinion pieces advocating that buprenorphine be made over the counter for opioid use disorder. What do you think about that?
I have more heartache about that.
Yeah.
Just because there is risk with that, right? And yeah, like you're not going to get dependent on naltrexone. Someone that's taking buprenorphine for an indication that's not appropriate, right? They'll become addicted eventually, and then you got issues to that, or they at least have some degree of dependence on it.
Right.
Maybe addiction's not the right word. Dependence.
Well, right. I mean, you could become dependent inadvertently, and it can be very hard to stop, especially if you didn't really have opioid use disorder.
And I do feel like there's a population I see now that want to be on buprenorphine that don't really meet criteria for opioid use disorder, right? I feel like I have people that come to me on it for alcohol, and they were started on this by someone else for their alcoholism, and I haven't seen data about that. And I feel like a lot of people are started on it for pain, and there's some evidence about depression now, and I feel like indications are getting a little loose at times.
It's a cure-all.
Yeah.
So, John, what were you thinking of in addiction medicine news this week?
You know, I was kind of in a disgruntled mood about our healthcare system over the weekend. I'm going to start by saying I'm a primary care doctor, and not to be political, but it's going to get political here for a second. You know, I was really upset about the CDC and RFK Jr. basically going back on his Senate hearing and kind of targeting vaccines once again. So just to kind of put that into everyone's radar, he specifically said during his Senate confirmation hearing that he would not propagate any anti-vaccine misinformation, that he would conduct rigid trials before he made any statements. And basically, he didn't do any of that and just kind of updated the CDC website to create distrust. And I was kind of thinking about this for other things. Like there's many other controversial areas that he talked about during his Senate confirmation hearing, which I'm very concerned about and are also dear to my heart, similar to vaccines. And I worry about kind of substance use treatment at this point. So, you know, he had spoken very openly about that he did not believe that kind of like medication-assisted treatment was kind of the way. He really advocated mostly for abstinence-focused strategies. In fact, he's been a strong proponent of healing farms. Do you know what those are?
Yeah, you go out to you work the lands, and that helps you get over your drug use.
Yeah, so you send people to kind of go pick strawberries and work the fields. And so it's kind of like manual labor-based recovery without medication. He's kind of favored.
But we need some people now because there's a lot of crops that we're struggling to grow and harvest now that we've, you know, sort of cracked down on our farming, you know, immigrant farmers.
Yeah. He's talked about the tough love approach being important. So like letting family members and other ones hitting consequences, hitting their rock bottom is being very important for recovery. And then he's really kind of made strong arguments about faith-based 12-step recovery, which, you know, I'm a religious person, but I feel that kind of government-mandated faith-based programs are in anyone's best interest. So, you know, that's kind of his preferential list of treatment strategies. And he had to kind of back off as well, saying that, you know, medications for alcohol, opioid use disorder, were still going to have a role, and that he wasn't going to limit things that save lives like, you know, overdose, education, naloxone distribution, syringe exchanges. Although I do wonder with him kind of basically lying to get confirmed and now kind of taking the stance that we all thought he would take. I wonder if these are going to be next.
Yeah, you know, I sent Bill Cassidy an email saying, do you feel bad that RFK just lied to you and you voted for him to be confirmed, assuming that what he said was the truth, and obviously it was a lie, and what are you going to do about it? I didn't hear back, though.
I bet you he's got about 100,000 of those emails.
And they're all from doctors? I mean,
I think there's some citizens, too, that also don't feel this way.
Just a few. I mean, the thing that's so offensive, John, and like, forget addiction medicine, didn't something like 50,000 physicians sign a petition begging them not to confirm RFK?
Yeah.
And they're like, who cares what you think? We're confirming him.
Yeah. So I'm just interested. I want to, you know, that was last year. I want to keep that on everyone's radar. Let's see what happens in the next 12 months as he's kind of reverting back to his unchallenged agenda. And I worry about my patients in recovery, especially with SAMHSA not really being there like it once was to kind of stand up and protect. HHS is kind of run by someone that's not in the medical field, to be honest. And the CDC is now, no longer reliable, spreading misinformation. It's a very sad time for public health.
And, living in a rural farming community, my patients don't really want to go to therapeutic farms, not seeing a lot of clamoring for that.
I never even heard of that term until I was reading about it.
I mean, heck, if you want to do that, like if recovery through like hard work and living in community and, out spending time outdoors is going to work for you, like that's awesome. Like great. But I really don't feel like that's going to come out on top as like the most effective treatment.
Although, you got those farmer markets and those co-ops and people like support them. Could you imagine a recovery, like therapeutic farm co-op that was selling you honey? That would definitely get a lot of people buying it.
It's true. If anyone in
be a side
recovery, wants to start a farm CSA, hiring mostly people in recovery to do the farm work, I'm sure you would be very profitable or at least compelling. But it can't be mandatory.
Maybe.
Oh my gosh.
All right,
On
let's
that
talk
note,
about teeth.
let's talk about teeth. All right. Some background. So this paper that I'm going to present, it's called Risk of Oral Health Problems in Adults with Opioid Use Disorder Treated with Transmucosal Buprenorphine. And this is an issue that's been percolating for a few years in the addiction medicine community and among patient communities, but this is sort of the newest paper on data about how buprenorphine affects our teeth. So in 2022, the FDA warned about possible oral health problems associated with transmucosal, so like you put it under your tongue or in your cheek, buprenorphine formulations. There was a case series, 305 cases of dental problems, 131 classified as serious, such as cavities and tooth loss. They were reported to the FDA adverse event reporting system. So, as you know, even after a medicine is FDA approved, you can still report to the FDA if you see a rare side effect that maybe didn't come up in the initial approval clinical trial. And they said now, quote, cases of dental caries, some severe, have been reported following the use of transmucosal buprenorphine containing products. Reported events included cavities, tooth decay, dental abscesses, dental infections, rampant caries, tooth erosion, fillings falling out, and in some cases, total tooth loss. Treatment included tooth extraction, root canals, dental surgery, as well as other restorative procedures. Multiple cases were reported in individuals without any prior history of dental problems. That's what the FDA said. And they put this warning on buprenorphine in 2022. And this caused a lot of distress. Some people felt like the warning was way overblown in a population at very high risk for dental problems at baseline anyway. And it would discourage people from seeking care for opiate use disorder in the middle of an overdose epidemic where 100,000 patients were dying a year of drug overdose. So, John, do you remember when this warning came out, and did any of your patients express concern about it?
There was some concern. I feel like it was more of like an afterthought for most of my patients, but it was something that I was surprised to see kind of published.
Yeah. Well, especially like so many of these patients have dental problems at baseline. So could it really be the buprenorphine? That was my question. Opioid use disorder is sort of lines up, correlates with a lot of risk factors for poor oral health. So people receive inadequate dental care. They have bad insurance. They have poor dental hygiene. They're not taking care of themselves. They have other medical comorbidities that lead to dental problems. They have poor childhood dental care. Often these people grew up in sort of chaotic childhoods and they didn't get adequate dental care as children. They smoke tobacco. They have dry mouth from medications, including opioids and other medications, psychiatric medications especially. And then finally, you may be dulling dental pain with the opioids you're using, either illicit or prescribed, and that leads to delay in dental care. I have a lot of patients who tell me that as soon as they got off their fentanyl or whatever opioid they were taking, suddenly they have all this dental pain they didn't have before because they weren't really feeling it. So you've got all these risk factors for dental care. So is buprenorphine really causing dental problems on top of all these other issues? That's the question. So this is a retrospective cohort study using data from one of these giant insurance databases. It's called the TriNetX Insurance Database. This insurance database itself has more than 80 million patients in it, all through their insurance records. And the group in this study was a cohort of 721,000 adults with opiate use disorder out of this database. So all you had to do was be an adult and have opiate use disorder via your ICD-10 insurance billing codes. This group included 45% women. On average, the age was 45, sort of the index age. 62% had commercial insurance. So, a slightly more better insured group than we usually see. About 3% had a prior diagnosis via ICD-10 of oral health problems. And in terms of race, the race was not well captured in this database, so I can't really tell you about the racial makeup of this cohort. They created 2 propensity-matched, non-overlapping cohorts similar in rates of prior dental problems. One group had insurance claims for buprenorphine, at least 3 prescriptions in a 6-month period, so a group treated with buprenorphine. And the propensity-matched other group had opioid use disorder but received no buprenorphine. So not exposed to buprenorphine, or at least not through legal prescriptions. The outcome were ICD-10 codes for new oral health problems like tooth decay, cavities, oral infections, loss of teeth, etc. They also looked at healthcare utilization through outpatient clinic visits. And these patients were followed for 5 years after their sort of initial date. And that was like the first presence of opioid use disorder as an ICD-10 code, or the first prescription for buprenorphine. And this was done over a 17-year period from 2002 to 2019. So again, a huge cohort, 721,000 patients with opioid use disorder in this study, looking at people who got buprenorphine and people who didn't, and seeing what the rate of dental problems were. So that's the setup. So John, what did you think of the clinical question?
I think it's like an interesting question that, I don't know, I was quite perplexed when this first came out, right? I feel like we've talked about this before, that opioids in general, like outside of buprenorphine, they cause xerostomia. They have known odontogenic effects, right? So we know that they're toxic to teeth. So I was surprised initially when they singled this out. So I'm kind of glad we have some sort of way of like trying to equalize this to actually see what is the true effect of the buprenorphine itself.
Yeah, I mean, I totally agree, and that's what's really hard to, really hard to sort out. Okay, so strengths and weaknesses of this trial. The connection between buprenorphine and dental problems is definitely biologically plausible. Like you said, opioids cause dry mouth, but it kind of goes beyond that. The mechanism of action isn't really known, but buprenorphine is hypothesized to cause dental problems via changing the oral flora biofilm. So it's physically in the mouth, it accumulates in the salivary glands, then softens the enamel via sort of acidity. And so it helps create this strep mutans biofilm, which then softens the enamel. In this Journal of Addiction Medicine issue, there was a second paper about salivary gland accumulation of sublingual buprenorphine compared to IV buprenorphine. So if it was IV buprenorphine, it didn't accumulate in the saliva. Sublingual definitely did. And this was a rat study looking at strep mutans on rats' teeth after they were given teeny weeny sublingual buprenorphine dots. It was a large cohort. As I said, 721,000 people, 156,594 in the buprenorphine cohort. They did weighted propensity score matching to sort of match patients in the control and buprenorphine groups. And follow-up was really long, at least 5 years from the index event. The groups were similar at the start of the trial. That's how the 2 groups were selected. They measured the exposures and outcomes the same in both groups. And the outcomes were clinically relevant. They were, dental problems. The problem with that, though, is that they were medical codes, not dental codes. So there were significant limitations to what dental diseases were captured in the ICD-10 codes. So we all know the limitations of medical billing. It just may not be accurate, especially in the case of opioid use disorder. But especially with dental issues, these ICD-10 codes, like A, would not include private dental offices. A lot of people pay cash for dental work. Dental work does not submit to insurance. Dentists don't use ICD-10 codes, actually. They use other different dental codes. So this database only captured ones that were kind of submitted kind of through medical. It wouldn't include patients who don't have any teeth at all. Then you don't have any dental problems. People who've had such severe dental problems that all their teeth have been removed. It only included these buprenorphine claims paid for by insurance, and especially in 2002, around the early 2000s, A lot of buprenorphine doctors didn't take insurance. It was a cash-only business. Also, patients getting treatment with buprenorphine are seeing clinicians more, and then they may be diagnosed more frequently with medical problems because they're going to the doctor all the time. They might say, yeah, let me ask him about my teeth and try to get in with an oral surgeon. And finally, because this is just a cohort study, there might be some unmeasured confounders, including geographic area, race, socioeconomic status. Those are all relevant factors in rates of tooth decay, and they weren't really captured in this study. So I think there were some real limitations to the data itself in terms of validity. So what do you think, John? Do you think this was a valid trial?
Yeah, I think it seems like it kind of had a lot of adjudication here. I guess my biggest issue is it's interesting about the dental claims data not necessarily following the ICD-10. It'd be interesting if there was a way to kind of pull that in since that's such a primary outcome here.
Yeah, and I mean, there's a dental coding. I don't know that much about teeth or how dentists work or how they code. I'm sorry.
I don't know either.
Yeah. So if you're a dentist and you're listening,
I wonder, like,
let us
do they have
know.
database limitations? Like, is it not quite as easily to extract all of that like it is some of our ICD-10 codes for medical billing? It'd be interesting to know if that could have been added,
Right. Is there a giant insurance database for dental codes? I don't know. So let's talk about the results. So basically, bottom line, people who were prescribed buprenorphine displayed a 1.24 to 1.3 higher adjusted risk of acquiring new oral health problems at 1 and 5 year follow-up. So yes, there was a connection between the buprenorphine and new oral health problems. So average time after the index date to the first diagnosis of an oral health problem was about 1.3 years in the buprenorphine cohort compared to 1.5 years in the control cohort. So your dental problems started a little earlier if you were taking buprenorphine. Second result, those taking buprenorphine had a higher risk of getting a new oral health problem at both 1 year and 5 year. The hazard ratio is 1.3 at 1 year and 1.24 at 5 years with a p-value of less than 0.001 in both cases following that first diagnosis of opioid use disorder. That buprenorphine cohort had consistently higher healthcare utilization, as you might guess, because they're getting buprenorphine, so they're using healthcare. The results were statistically significant and I thought clinically significant. There was a number needed to harm of 125 people at 5 years. So that's kind of a lot. You would have to give 125 people buprenorphine, at least 3 prescriptions over a 5-year period to cause one serious dental problem. So, that seems like a pretty big number needed to harm. But then if you look at the fact that almost, many, many dental problems were not captured in this database, this is just the most severe ones that were submitted through medical insurance. And my personal experience is that means it was really bad if your medical insurance is paying for it. I think it is a relevant difference. So trying to look at actual numbers from this study in terms of percentages, let's go to 5 years. At 5 years out, patients who got buprenorphine, 9.2% had a new oral health problem. Patients who didn't get buprenorphine, 8.4% had a new oral health problem. And that's where I got the number needed to harm of 125, comparing those two numbers. And again, they seem a little low. I mean, if you take any group of middle-aged people and follow them for 5 years, I would think at least 8-9% would have a new dental problem. It's just part of life. The baseline rate of dental problems in this study was about 3%. Again, just seems low. I had looked it up. What is the rate of dental problems? And it says 1 in 5 adults aged 20 to 64 have at least one permanent tooth with untreated decay. 17% of adults have lost all their teeth in the U.S. The worst state for dental care is West Virginia, of course. So poor West Virginia. 55% of adults in West Virginia have lost at least 6 teeth. But again, these aren't really fully coded for in the database they were looking at. The other thing that was interesting is that the hazard ratios were relatively stable over time, indicating that the change in dental problems really took place early on in treatment with buprenorphine. And the dental effects appear to be somewhat idiosyncratic rather than consistent and cumulative. Basically, some people will have significant dental effects from buprenorphine and other people are fine. It's not a consistent result. There wasn't a lot of data on cumulative use of buprenorphine, They did have a group that had filled at least 9 prescriptions, and those people did have higher rates of dental problems than the people who'd filled 3 or more prescriptions, but 9 prescriptions for buprenorphine over a 5-year period is still a pretty low number of prescriptions. I mean, my patients will fill, like 12 to 20 prescriptions a year. So even 9 prescriptions over a 5-year period is not that much buprenorphine. So I don't know if it tells me much about people who use it really consistently over the long term. So, John, what do you think of those results?
I think it's interesting that from that there does seem to be an effect, although you're right, it seems like a relatively minor effect compared to like what I would think for baseline in the background of our population.
Yeah.
It's tough to say. Like, I think this is something to counsel patients about, like the importance of dental health, although I find a lot of my patients in this population do have dental health issues at baseline. So it's something we're talking about and dealing with as well. I'm not sure it's something, though, that's like a deal breaker for me or that I would counsel against treatment. I still feel like that the benefits so far outweigh the harms here.
Well, definitely, especially the harms demonstrated in this study, which was a number needed to harm of 125 people. And actually, this time I remembered to write the author of the paper prior to presenting instead of waiting till after I present and then just wondering stuff about the article and writing the author afterwards. So I did get a very nice email from the author of this paper about it. And they said, yeah, basically, the correlations would be even stronger if they had access to comprehensive EHR data from both medical and dental practices. But since they only have medical, it really is an incomplete picture of the dental harms caused by buprenorphine. So in terms of how this has changed my practice, I mean, benefits of buprenorphine are huge. The number needed to treat is 2 for resolution of opiate use disorder historically. In this paper, number needed to harm is 125 for dental problems caused by 3+ scripts of buprenorphine. And with that calculus, I definitely would recommend buprenorphine for opiate use disorder. If I assume dental problems are a lot more prevalent, I would still recommend buprenorphine for opiate use disorder. And this article has sort of reinforced a little bit my practice of counseling people about dental health. And, I recommend that they see a dentist. I provide a list of dentists that accept state medical insurance. I talk about dental hygiene. And then I did pick up a tip from looking into this, which is that you can mitigate some of the risk by not brushing your teeth within an hour of using your transmucosal buprenorphine, because the enamel will be soft after you use it. And then if you brush right when that enamel has been softened, you can kind of wear it away. So I would tell people not to brush their teeth within an hour of taking their buprenorphine. And if someone really is concerned, I would prioritize injectables, because this other study I talked about done in rats showed that the IV buprenorphine in the rats didn't accumulate in the salivary gland the same way the transmucosal did. So yeah, you could do injectables if you wanted to. So overall, I feel like the accumulated evidence does support the FDA's warning and SAMHSA's recommendation for clinicians to counsel patients about both potential oral health risk and ways to mitigate this risk associated with transmucosal buprenorphine. But I don't want to deter anyone from taking it to treat their opiate use disorder. That's sort of my conclusion.
I'd be interested to see it in this era of depot buprenorphine, like in the future. Do we have like some more data besides a rat study to show the effects of the subcutaneous versus the oral? Is there really a substantial difference there? I mean, I would like to just see like the real world conditions of something like that at some point.
Yeah, if you're a dental researcher out there and you want to, I'm very interested in the bacterial biofilm that caused tooth decay. So if you've done this study, please let us know.
Thanks for that was a great article. Very interesting topic. I feel like dental health just comes up so much. And, as a medical doctor, I mean, very limited training in dental health is something that comes up all the time, right?
Well, right. And we're in an area, St. Max is where they don't fluoridate the water. So it was something I had to contend with when we moved here, providing fluoride to my own kids for their dental health. So that was interesting.
Well, thanks for presenting that. We got some talk back from some previous episodes. So this was from Dr. Sarah Spencer regarding episode 67 on injectable buprenorphine. I'm an addiction medicine specialist working at tribally run clinic in rural Alaska, and we have been doing rapid cold starts of buprenorphine at our clinic for about 5 years. We find the patients really love this low threshold rapid start approach. Our patients can receive their injection at walk-in appointments, and they can be given by other staff members such as nurses or community health practitioners in the tribal health systems. We don't require any drug tests for our patients to get their injections. We utilize 300 milligrams Sublocade, and in the past year, our mobile clinic, over 80% of new patients chose to start their Sublocade while they were still using fentanyl or heroin without taking any sublingual buprenorphine. We also counsel our patients to continue to use fentanyl or take high-dose sublingual buprenorphine for the next 24 to 48 hours until their withdrawal symptoms resolve. A recent patient satisfaction survey was conducted at our clinic of 25 patients to the rapid start. 2 out of 3 of them had little to no withdrawal symptoms. About 1 in 6 experienced severe withdrawal symptoms during the first 24 hours, but 95% of patients would recommend to a friend to do a rapid start. 2/3 of patients utilizing our mobile clinic got their second shot administered on time. It's also very important which formulation you use and where you administer it. Weekly Brixaldi and monthly Sublocade have slow onset of action over 18 to 24 hours, so they act as a rapid micro dose and are generally well tolerated for cold starts. However, monthly Brixaldi comes on very fast and may be more likely to trigger a weekly precipitated withdrawal. Also, when you give a shot, it is important. We always give the shots in the abdomen as administration of Sublocade. The arm has a much more rapid onset. We generally prefer Sublocade because it has higher peaks and drug levels and longer half-life. So it's a long talk back, a lot of information there.
Well, yeah, and she sent us more information. I didn't want to go through all of it, but like, I just think it's so interesting. The bottom line is, if we make things more complicated than they have to be.
This sounds familiar. Was she a speaker at ASAM like a couple of years ago?
She was an amazing speaker at ASAM the year we went.
Yeah,
She gave
this
a
sounds
great
familiar.
talk. We love you, Dr. Spencer.
Yeah, I remember hearing this talk. I was like, this sounds very familiar.
Yeah.
Unless there's another rural tribal Alaska person doing really cool new onset stuff. So that's awesome.
Yeah, and well, it's just cool because basically, right, like patients don't have to get a sublingual prescription. They don't have to go through withdrawal. They don't have to start sublingual, titrate up, wait however many days. They can just get that injection the day they want, and they can use their fentanyl to treat their withdrawal while it's kind of kicking in.
Isn't it funny when we start something new, there's always these long protocols like in-office inductions, 2 milligrams every hour. And then everyone's like, we don't need to do all that. Like, let's just get the job done.
Well, right now we're seeing that with the injectables,
That's great.
Just give it. It's awesome.
Well, thank you for listening to the Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno, CME support from My Cares, produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employers or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.